Hi, my name is Dan Soffer, and I'm past president of the National Lipid Association, and I'm thrilled to have this opportunity to be joined by Alexis Baass to talk about his recent prize for the Donald Hunting Hockey Award. And Dr. Baass, thank you for joining us at the NLA Scientific Sessions.
Well, thank you for the invitation. It's a great honor to have received this prize through the NLA. So I've been working in the field of FH research for more than 10 years now. Initially, I'm a medical biochemist. I specialize in lab medicine at the McGill University Health Center. But I did a fellowship in the field of lipidology in Dr. Davignon's lab, who is one of the founding members of lipidology in Canada and in Quebec. And so since then, I've been interested in this field and working in research. As you might know, we have a genetic founder effect of FH in the province of Quebec, and therefore we see many of these patients. So that sparked my interest to understand how can we better stratify the risk of cardiovascular disease to better treat these patients with maybe more personalized medicine. So we've been working on this question for quite a while now, initially looking at, just the standard cardiovascular risk markers that are present, in pretty much everybody, as measured in the Framingham risk score or PCE, that are not really well calibrated for FH patients. So one of our initial publications, so to speak, was to look at that. And so we developed a specific score initially, the Montreal FH score that we did publish in the Journal of Clinical Lipidology, and it was very well received. I think people were interested in this concept of further risk stratification in FH, and also perhaps, starting to look at more personalized medicine, because as you know, initially we didn't have so many therapeutic options, lifestyle, yes, for sure, statins, and we started having more and more potent statins, so we worked in that. Then ezetimibe dropped, so that was, again, another game changer, but it's modest. And now we have the PCSK9 inhibitors. So we have so many different options, and I don't know how it is in the US, but in Canada there's always some budget constraints. So we're thinking, who are the patients that should be first treated, that would benefit mostly from these therapies, maybe early on, at early age. So that's the whole idea behind this, the concept of trying to identify the risk, and with now these genetic polygenic risk scores maybe earlier than before. So that's where our interest came from.
Yeah, I'm fascinated by the concept of stacking risk factors and polygenic risk score on top of pathogenic variants that cause familial hypercholesterolemia seems to me a low-hanging fruit, especially in a population like yours that has such a strong founder effect.
Yeah, you're absolutely right. Initially, it was a bit counterintuitive. Maybe many people ask us, well, what's the point? You need to treat them regardless. And that's absolutely true. All FH requires statins, and that's the baseline for everybody. But the question is, now that we can go further, should we always go further? And when should we go further? Earlier. So these are, I think that's what we're trying to work on, try to bring a little piece of the puzzle, so to speak. And so initially with the Montreal FH risk score, then the FH risk score, that was a multinational cohort, and now looking at these polygenic risk, because, as you know, these genetic exposures start in utero, right? And the risk starts during childhood. There's many excellent studies showing that earlier you diagnose and earlier you treat, more benefit you get. And we do see this heterogeneity in the risk factors. But this genetic heterogeneity is difficult sometimes to identify, especially many of these polymorphism associated with the CAD risk are not necessarily polymorphism associated with biomarkers that we can measure. For example, they're not necessarily associated with LDL, ApoB, LPA, or others as well. So many of these SNPs in the polygenic CAD were actually independent of other risk factors. So that's another finding that's quite interesting, is that in our study, the polygenic risk really was independent of all other classical risk factors. So we're pretty excited by that. The next step for us really is to try to put everything together, because the big question that everybody asks, how do you translate it to the clinical setting? Not many labs offer these tests. I've gone around to the booths, and a few people offer these tests, but again, there's a lot of heterogeneity in the panels. You have very small panels, you have genome-wide panels, so there's heterogeneity there. There's also the big question of reimbursement. Mostly they're not reimbursed. But I think offers a lot of clinical relevant information that if we could harness, we could make better clinical decisions. So our next step is to try to integrate that, FH risk score, classical risk factors, and all these extra genetic pieces of information for risk prediction.
Yeah, risk prediction, of course, is a holy grail for everything we do. But as I'm talking to you, I'm thinking, some of the FH patients we see seem to have extraordinary risk, but some of them seem to have some protection. Have you seen any clinical trials or clinical data about polygenic protection scores as opposed to risk scores?
Absolutely. That's an excellent point. I mean, some people would like to know that the risk is less than average. Again, it's not to withhold statins. I think that's extremely important.
Yeah.
But still, maybe they don't require add-on therapies. It could also, maybe less stress in their life, knowing that they have this protection. But so, yeah, we did look at the patients with a very low polygenic CAD score, so under the 5th percentile, and they had significantly less event than the rest of the cohort. So now, again, another point is to try to compare to the general population. So we're going to do that through studying the UK Biobank data to see if you have an FH treated with statin with a low polygenic score, how does that risk compare? And so to give us an idea of, do we need to go further in these patients, or are we doing enough? But it's always when we talk about FH, we always want to throw the book at the patient. Maybe there are some situations where we can maybe step back a bit.
Yeah. So, years ago I had heard, I don't think it was you, I have to just go back in my memory, I heard one of your colleagues, I think, talking about the genetics of inherited lipid disorders in Quebec, and that apparently the St. Lawrence separates the triglyceride disorders from the FH disorders.
Yeah,
do you know anything about that?
Well, that's an excellent point. Through migrations that were really restricted initially to French migrants, the province of Quebec, so the French Canadian population, really inherited some mutations in both LDL receptor leading to FH and lipoprotein lipase leading to familial hypertriglyceridemia, but more importantly familial chylomicronemia, unfortunately. And so this is where Dr. Godet has an expertise, and we're fortunate that we have all these new drugs to eventually treat these people. But yeah, I mean, it's unfortunate for the population, but it's maybe interesting scientifically. Now and in our province, fortunately, we have had access to genetic testing for a long time. Yeah. So that allowed us to identify and try to treat these patients early on.
Is the specific genotypic pool different in Quebec with regards to FH, or is it really just a microcosm of the same pathogenic variants that we see around the world?
Yeah, so that's an excellent point. The fact is there are 5 founder mutations in the LDL receptor that are really prevalent in the French Canadian, but more and more as the rest of the world with immigration, we're starting to see all these other mutations. So in Quebec, you have a very sizable French Canadian population, you have an Anglophone population. In the Anglophone, we see pretty much all the same mutations as in the US, for example, and on all, with all the immigration, we see pretty much everything nowadays. Yep.
Yeah. Well, this has been fascinating. I love listening to you. I can't wait till you're up on stage presenting at the NLA, hopefully at a coming meeting soon. Your work has been tremendous. I think to receive the Hunting Hockey Award is testament to the work that you've given to our community and what we've all learned from you. Every time I see an Alexis Baass paper, I'm quick to read it. It always captures my interest.
Well, thanks.
Thanks, Alexis.
I appreciate this a lot. I mean, it's a great honor to be here to present the data. As a scientist, you always want to, show the data to the rest of the world so people can use it, in their own setting, try to improve healthcare one little brick at a time, Yeah. So. Thank you very much.
Great. Thank you. Thanks again. And thanks for listening to our little session at the NLA Scientific Sessions.
Thanks all.
Great. Perfect.